In this lecture, we'll be discussing about hypermetropia. Now, the definition hypermetropia, as we know, it is long-sightedness. That is, the parallel rays of light coming from infinity are focused behind the retina when the accommodation is at rest. So this is the normal eyeball, and this is the normal refraction of the light rays coming from infinity. That is, they're focused at the retina. Whereas in an hypermetropic eye, the image is focused behind the retina when the accommodation is at rest. Now, the etiology of hypermetropia, it can be remembered by the mnemonic pica, P-I-C-C-A-A. Now, P refers to positional hypermetropia, that is the position of the lens. It results from the posteriorly placed lens. Next is index hypermetropia, that is there is a decrease in the refractive index of the lens in old age. Third is curvatural hypermetropia, that is the cornea, lens, or both the cornea and lens are flatter than normal, resulting in decreased refractive index. Now, for every 1 millimeter increase in the radius of curvature, there is 6 diopter of hypermetropia. Okay, so this is about curvature hypermetropia. Next is consecutive hypermetropia. Now, this may be due to overcorrected myopia during following refractive surgery or underpowered intraocular lens implantation during cataract surgery. Okay, so overcorrected myopia. Remember, in myopia, the light rays meet in front of the retina, and if there is overcorrection, the image may be formed behind the retina. So this is about the overcorrected myopia, and the second is underpowered intraocular lens implantation during cataract surgery. So this is about consecutive hypermetropia. Next is axial hypermetropia. Now, here the total refractive index is normal, but there is an axial shortening of the eyeball. Okay, that is, for every 1 millimeter decrease in the anteroposterior diameter of the eyeball, there is a 3 diopter of hypermetropia. So again, axial means the refractive index of the lens is normal, but there is a decrease in the axial length, as you can see in this diagram. And finally, the sixth cause is absence of crystalline lens or aphakia, and this may be congenital or acquired, and this results in high hypermetropia. So again, the etiology of hypermetropia, remember, pica, posterior positional hypermetropia due to posteriorly placed lens. Index hypermetropia, that is, in old age there is a decrease in the refractive index of the lens. Then curvatural hypermetropia due to the flattening of the cornea, lens, or both the cornea and lens. And for every 1 millimeter increase in the radius of curvature, there is 6 diopters of hypermetropia. C is again for consecutive hypermetropia following surgeries such as refractive surgery or cataract surgery. Then we have axial hypermetropia, that is due to the shortening of the anteroposterior length of the eyeball, and for every 1 millimeter decrease in the anteroposterior diameter, there is 3 diopters of hypermetropia, and finally it is aphakia. So this is the etiology. Now, coming to the clinical types of hypermetropia, there are 3 types. The first is physiological hypermetropia, the second is non-physiological hypermetropia, and the third is functional hypermetropia. Now, physiological hypermetropia, it includes the developmental axial hypermetropia and the developmental curvatural hypermetropia, which is due to the changes in the physiology of the lens. Second is the non-physiological hypermetropia. Now, this may be congenital or acquired. Now, the congenital causes are microphthalmos, nanophthalmos, congenital aphakia, congenital posterior subluxation of the lens. Okay, so these are the congenital causes of non-physiological hypermetropia, and the acquired causes of non-physiological hypermetropia, as we've discussed, is pica, that is positional, index, curvatural, consecutive, axial, and aphakia. Then the third is the functional hypermetropia, which is due to the paralysis of accommodation seen in third nerve palsy or internal ophthalmoplegia. So this is the clinical types. So again, physiological, non-physiological, which is of congenital and acquired types, and functional, which is due to loss of accommodation due to third nerve palsy or internal ophthalmoplegia. Now, a small note: depending upon the effect of accommodation, hypermetropia can be classified as latent hypermetropia or manifest hypermetropia and total hypermetropia. Now, latent hypermetropia means that hypermetropia is present, but it is corrected by the inherent tone of the ciliary muscle. Next is manifest hypermetropia. Now, here the hypermetropia is not corrected by the inherent tone of the ciliary muscle, and it includes two things. The first is the facultative hypermetropia, and the second is absolute hypermetropia. Now, facultative hypermetropia means that the hypermetropia is corrected by the patient's accommodative efforts, and if it is not corrected by the patient's accommodative effort, it is known as absolute hypermetropia. And finally, there is total hypermetropia, that is the combination of both latent and manifest hypermetropia. So again, depending upon the effect of accommodation, hypermetropia can be divided into three: latent, manifest, and total. Latent means that it is present, but it is latent. Why? Because it is corrected by the inherent tone of the ciliary muscle. Next is manifest hypermetropia, that is it is not corrected by the inherent tone of the ciliary muscle, and it may be facultative, that is the person's accommodative effort can correct the hypermetropia, and if the accommodative effort does not correct, it is known as absolute hypermetropia, and if both are present together, it is known as total hypermetropia. So we've discussed the clinical types and the types based upon the effect of accommodation. Now coming to the clinical features of hypermetropia, it can be divided into symptoms and signs. Now the symptoms, it may be asymptomatic. There may be asthenopic symptoms, that is the symptoms due to eye strain. So these include tiredness of the eyes, frontal headache, watering from the eye, and mild photophobia. Okay, so first is asymptomatic. Second is asthenopic, that is due to eye strain. Third is defective vision only, that is high hypermetropia. The patient does not accommodate, and then hence there is defective vision. And fourth is a combination of both defective vision and asthenopic symptoms. So again, the symptoms are, it may be asymptomatic, asthenopic symptoms due to eye strain such as tiredness of the eyes, watering from the eyes, frontal headache, mild photophobia. Defective vision only, or combination of both defective vision and asthenopic symptoms. Now coming to the signs of hypermetropia, the size of the eyeball, it is usually small. The cornea is also smaller than normal. The anterior chamber is shallow. Okay, all of this is due to the smaller eyeball. Because of the smaller eyeball, there is smaller cornea, and because of this, there is the anterior chamber also appears shallow. So these are the first three signs. Next is retinoscopy or autorefractoscopy, and this reveals a hypermetropic refractive error. Fifth is the fundus examination, and when you look into the fundus of a patient with hypermetropia, you observe a small optic disc which is more vascular with ill-defined borders, and this resembles the fundus view of papillitis, and hence this is also known as pseudopapillitis. The retina may appear shiny, and this is known as short silk appearance. This is about the fundus examination. And finally, A-scan ultrasonography, it reveals a shorter anteroposterior length. So again, the signs are, remember the eyeball is small, hence we have a small eyeball, small cornea, and a shallow anterior chamber. Then retinoscopy and autorefractoscopy reveals hypermetropic refractive index. Fundus shows pseudopapillitis and short silk appearance. Then A-scan ultrasonography will show shorter anteroposterior length. So this is the the signs and symptoms of hypermetropia. So remember the symptoms again: asymptomatic, asthenopic, defective, or combination of both defective and asthenopic symptoms. And remember the asthenopic symptoms as tiredness of the eyes, frontal headache, watering from the eye, and mild photophobia. Signs due to a smaller eyeball, that is small eyeball, small cornea, shallow anterior chamber. Retinoscopy shows hypermetropic refractive error, and fundus examination you see pseudopapillitis and short silk appearance, and A-scan ultrasonography anteroposterior length is shortened. Now grading of hypermetropia, it can be done as low, moderate, and high. Now if the error is less than +2 diopter, it is known as low hypermetropia. If it's between +2 and +5 diopter, it is known as moderate, and if it's greater than or equal to 5 diopters, it is known as high hypermetropia. So again, less than 2 low hypermetropia, between 2 and 5 moderate hypermetropia, and more than equal to or more than 5 is high hypermetropia. Now the complications. Now the first is, to relieve accommodative strain, the patient may repeatedly rub the eyes, and this may introduce infections and result in recurrent styes, blepharitis, and chalasia. So the first is due to repetitive rubbing of the eyes, which results in recurrent stye, blepharitis, and chalasia. Next is accommodative convergent squint due to excessive use of accommodation. So if this is the normal eye, because of excessive accommodation, there may be an accommodative convergent squint, that is the eye appears like this. Okay, convergent squint. The third is amblyopia, and the fourth is predisposition to develop primary narrow angle glaucoma. Why? Due to the shallow anterior chamber. So again, complications: To relieve the accommodative strain, patient may continuously, repeatedly rub the eye, resulting in recurrent styes, blepharitis, and chalasia. Next is because of excessive use of accommodation, there may be a accommodative convergent squint. Third is amblyopia, and fourth is predisposition to develop primary narrow angle glaucoma due to the shallow anterior chamber. Now, the treatment of hypermetropia, it may be optically corrected or surgically corrected. Now, the optical treatment, it includes basically the use of convex lens to converge the light rays onto the retina. Now, the fundamental rules to prescribe glasses are: the first is that the total amount of hypermetropia should be determined. Second, the spherical correction should be comfortably accepted by the patient. Third is that the gradual correction is increased at 6 months interval till the patient accepts manifest hypermetropia. That is, manifest meaning the inherent tone of ciliary muscle does not correct hypermetropia. Okay, so until the patient accepts manifest hypermetropia, the power correction is increased at 6 months interval. And third is that the accommodative convergent squint, if present, then full cycloplegic correction should be given. So these are the fundamental rules to prescribe glasses. Next is a mode of prescription of convex lens. It may be in the form of spectacles or contact lenses. So this is the optical treatment. So basically, remember, we use convex lens to converge the light rays onto the retina. Remember the fundamental rules to prescribe glasses and the modes of prescription, that is spectacles and contact lenses. Next is surgical treatment. Now, the surgical treatments are hyperopic LASIK surgery, thermal laser keratoplasty or TLK, conductive keratoplasty, implantable contact lens, and refractive lens exchange. So these are the surgical treatment: hyperopic LASIK surgery, thermal laser keratoplasty, conductive keratoplasty, implantable contact lens, and refractive lens exchange. And with this, we finish off our discussion on hypermetropia. So we've discussed the definition, the causes, that is pica. Then we discussed the clinical types: physiological, non-physiological, and functional. We also discussed the types based on the effect of accommodation, that is latent hypermetropia and manifest hypermetropia and total hypermetropia. The clinical features, the symptoms and signs we discussed, that is asymptomatic, asthenopic, defective vision, and combination of defective vision and asthenopic symptoms. Then the signs due to a small eyeball. Then fundus examination showing pseudopapillitis and short circuit appearance, and A-scan ultrasonography showing reduced shorter anteroposterior length. Then the grading, remember, less than 2, 2 to 5, and greater than equal to 5. Then the complications we discussed and the treatment.